So hi, my name's Jonathan, and I'm one of the psychologists at Tara. We're actually a permanent team of 7 psychologists, 2 community service psychologists, and at the moment I think we have 9 interns. So it's quite a big team. And then of course we have psychiatrists, social workers, OTs, a large nursing complement. And here today with me is Dr. Ramasar over there. She's one of the psychiatrists in one of the closed wards. Navida Hurson, who's the head social worker. And Thabo Modisani is another social worker who also works on one of the biological wards, and Navida works in the psychotherapy ward. I was going to say personality disorder, but it's a psychotherapy ward. And I suppose we deal with some homeless people occasionally when they eventually get to us, and if we can start the presentation. It was very difficult to do some research on the topic, because I suppose when we have homeless or dislocated people at Tara, we generally treat them like most other patients. And there aren't very reliable stats out there, but Dr. Ramasar and I sat the other day and we were looking through some of the resources. And so we thought we'd start off with a general idea of how many psychiatric patients there are out there in the general population. And some statistics suggest that about 16.5% of the general population has a mental illness. Now, if we take South Africa as having 49 million people, that's just over 8 million people in this country are mentally ill. I found in some of the literature overseas that some figures are as low as 5%, but some are as high as 25% of the general population with a mental illness, depending on where you look. So I think 16.5% sounds like a fair average. Now, of those psychiatrically ill, we have approximately a third, or 26.5% of them are severely ill. And that amounts to approximately 2,118,270 people in this country who are severely psychiatrically ill. And this means that they're not able to function in their daily lives. So they're not actually able to fulfill their daily activities of living, I think, which means work, relationships, keeping a home, maintaining themselves. So severe mental illness is chronic and progressive, which means that it lasts a lifetime and it gets progressively worse. So people's functioning declines over time, and they get more and more dysfunctional and more dependent on support structures, which starts to, I hope, in your mind, make you link the homelessness and severely psychiatrically ill patients. Now, the 2 resources that I looked at about homeless people and psychiatric patients was one, the California Psychiatric Association, which suggests that up to 40% of homeless people in California are psychiatrically ill. And the one news report that I found actually I think Dr. Ramasar and I found it together, in Canada, suggested that about 10,000 people a night in Canada are homeless and psychiatrically ill. Now the interesting thing about that, and I'll go back one, the interesting thing about that is that according to this article, they said that there's a higher rate per capita of homeless and psychiatrically ill in Canada than in America, which was interesting. We don't really understand why. They hypothesize different reasons, but ultimately you'd think a country like Canada, with the kind of social resources that they have, might have fewer psychiatrically ill patients on the streets, but they actually apparently have a percentage higher than the States. Okay, next. Now, it's difficult to identify any one reason why people the psychiatrically ill end up homeless. But we thought we'd open up maybe a few ideas about why they might end up that way. In the USA and in England, many years ago, there was a move to deinstitutionalize patients. And that came from an ideology around how inhumane, the one flew over the cuckoo's nest, how inhumane psychiatric hospitals were and how inhumane psychiatric treatment was. And so it was much better to treat patients at home or in their communities, and they tried to reduce hospital stays and provide community care. The problem was that none of that community care really materialized. So people were shipped out of the psychiatric hospitals and weren't received in the community. And we think that that's one of the ways that people then became homeless, especially in those areas. So the problem is that the rest of us in South Africa as well thought that was a wonderful idea to deinstitutionalize, and that there's enormous pressure here as well to deinstitutionalize patients and to try and keep them in hospital for as short as possible, to get them stable quickly and then move them back into their communities. And I'm one of the people that are of the opinion, because I can't say I don't want to get anyone else into trouble, but I'm of the opinion that that's not necessarily a good idea, because all it means is that we have a lot of pressure on beds, there's reduced resources directed at institutions like Tara or other psychiatric institutions, and that there isn't enough community-based care. We simply don't have the resources, the trained skills, the professionals, the money to provide the very intensive care that patients need in their community. So what happens is that what we call a revolving door is that patients leave, and it depends where they are, some weeks later or some months later, they come back. And I'm not sure that saves the state any money either. The other problem is, and this is also very difficult to researchers, is dislocation, which are refugees. And I've got a book called The World Mental Health, well, just World Mental Health, which was published in 1995, which I picked up secondhand at Wits Library. Well, I think £2. And those authors suggested about 20 million refugees, that there were at the time, in 1995, about 20 million refugees worldwide, officially with the United Nations. Mostly from Asia and Africa, and then they say that there are also 20 million people displaced or dislocated in their own countries. And that means migration, economic refugees, refugees that leave because of natural disasters, because of conflict. I mean, just think of Darfur recently. And this migration in countries or across borders results in enormous pressure of people to try and adjust to a new environment, to new languages, to new structures socially, and can be very traumatic, because firstly, you're a foreigner, an alien who's come for reasons other than, say, affluent, seeking higher paid jobs in other countries, but because you're seeking food and shelter. And the local community often doesn't like foreigners who are perceived to take jobs and to drain the state of its resources. And so they experience, apart from their own experience of adjustment difficulty, which migration is an enormous trauma in and of itself, also the lack of support and access to resources that other patients might have or other people might have. Sorry, I speak of patients because that's the people we work with. Next slide. Then, of course, we were thinking around stigma, because stigma is quite a big issue in psychiatric illness. I think if I had to ask most of you how you felt about one of our clinical head recently did a talk at our mental health day about stigma, and she asked a very poignant question. She said, how many of you would employ a chronic paranoid schizophrenic to look after your 3-year-old? And why not? And the reality is that I think even in our own camp, we would be uncomfortable with that idea, depending on who the person was, of course, because you wouldn't just let anyone look after a 3-year-old child, but why not a psychiatric patient? And there's a lot of prejudice against psychiatric patients, which means that they're further ridiculed, they're isolated, they're stigmatized in their own community, in their family, and that could also means that they're even more vulnerable, and that they're already got a pretty low capacity to manage everyday stress. It's made even worse by the stigma and the prejudice. And then there seems to be in the media, One Flew Over the Cuckoo's Nest comes to mind, or any other horror movie, that patients, psychiatric patients, or the violent serial killer is a psychiatric patient who will come after you. And that's not really true. I mean, we have some very few, small minority of psychiatric patients who might be violent or dangerous. And that's a very particular type of psychosis, I guess. But generally, the psychiatric patient who ends up violent or aggressive is the patient who hasn't been treated properly or has been untreated in the community, has experienced enormous amounts of ridicule and isolation, and eventually, when they can't access the help that they need, they become aggressive. Excuse the stray bullets. So then that was just to give you an idea of the kinds of reasons why people end up as psychiatric patients, or who are psychiatric patients that may end up homeless. But the reality is also that you need to differentiate when you're working with these patients that some psychiatric patients might not be psychiatric patients. That sometimes symptoms or psychiatric symptoms may be as a result of other things. And that's quite an important thing that I'd like to convey, because you can't just find a homeless person and bring them to Tara, because Tara is actually a, I think, tertiary or quaternary institution. We only take referrals from the general hospitals or the secondary hospitals like Joburg Gentian and Joseph Barra, because ultimately, if you take someone who's behaving a bit strangely on the street to us, we need to make sure that they're not suffering from a medical condition, because medical conditions can often mimic or mask I'm doing it the wrong way around. So psychiatric symptoms may often mask or mimic medical conditions. So if a person's had a stroke, or they're diabetic and they're having some kind of diabetic event, or they might have had some kind of head injury or thyroid problem, all those issues result in psychiatric symptoms. And they need to be cleared and assessed in a general hospital where there are facilities to treat the medical condition. Because if you actually take someone who's got a medical condition to us and it's not picked up and something happens, we're all in trouble, because ultimately those things can be they can be medical emergencies. There may be substances involved. So often you can have drug-induced psychotic episodes or drug-induced depression. And those patients need to be treated at drug rehabilitation centers, because once the drug is removed and there's a residual psychiatric problem, then we will help them as well, because that's what we treat. And unfortunately, there are very few substance abuse rehabilitation centers in Johannesburg, and it's difficult to get patients into them. But we also don't have the facilities to deal with them at Tara, because they require very specialized care. Hopefully in the future that might happen. It can also be part of a cognitive impairment, like I said earlier, head injury or mental retardation. Can also have some psychiatric symptoms involved. But those are best treated, again, in other facilities or homes for such patients where they have the care that they need. So that is why when you maybe see an individual displaying odd or bizarre behavior, having odd or bizarre beliefs, poor self-care, and I mean these are all bullet points, but the reality is odd or bizarre behavior is really odd or bizarre behavior. When you see the bag lady, I don't know if any of you go to Rosebank, there's a bag lady who wanders around and she wears the same clothes. I'm sure she doesn't smell very good because she probably doesn't shower very often, and she speaks to herself and she doesn't make eye contact. That's odd or bizarre behavior. I don't know if she speaks to anyone, but she might have really odd or bizarre beliefs. It might be the person who's running down the road naked, telling you all about Jesus and salvation. That kind of odd or bizarre behavior. Very extreme stuff, not the average eccentric, idiosyncratic stuff. Otherwise, I think we'd all be psychiatric patients. Poor self-care is when patients, for example, when someone's very depressed, they stop washing. They stop washing their home or cleaning their home or their clothes or their dishes, feeding their pets, their children. That's poor self-care and care for others. Marked decline of previous functioning and behavior. Marked decline being marked decline. So if someone's suddenly, or over a period of time, if it's suddenly, it's probably more organic and a medical condition, but if over a period of time they are not performing at work, they start fighting with their colleagues and their partners, they become aggressive over time, they get fired for whatever reason, those are all early signs and symptoms of a potential psychiatric condition emerging. It doesn't necessarily mean that though. It could be. Extreme and prolonged changes in mood, sleeping patterns and appetite. Somebody who's got a healthy appetite, who suddenly stops eating. Or someone who eats on an average amount and suddenly starts to binge eat for weeks and weeks and putting on a lot of weight, that's significant. If someone suddenly seems very down, or over a prolonged period, very down, and they just don't enjoy the stuff that they used to do. So even if this person, say, would enjoy going to movies usually, or meeting with friends, and suddenly none of that means anything, that can be significant. Libido is significant as well. If someone who was previously quite a vibrant person who does lots of stuff and then they don't enjoy anything anymore, significant. Of course, the hearing voices, it's quite a, we all know about hearing voices, excessive fear or paranoia, rumination if they're completely overwhelmed by ideas in their mind, social withdrawal and isolation is significant, agitation and restlessness if someone's constantly pacing and just not able to sit still ever, something might be going on. And then, of course, victims of severe stress and trauma are more vulnerable to psychiatric illness. Now, the thing is that these patients don't necessarily have a psychiatric condition. They may have a psychiatric condition, and that's why they need to be assessed by a multidisciplinary team. That's why we have ward rounds where the whole team comes together, the social workers, the OTs, the psychologists, the doctors, and we interview patients and we try and assess and diagnose what they might have, and then the appropriate treatment is started. So if you see someone like that who happens to be homeless, who's sleeping somewhere in the park, and who's talking to themselves, and obviously their self-care might not be as good, but it's not to say that that's necessarily true, because there are lots of people who are living in squatter camps who actually take very good care of themselves, and whose clothes are always clean, and you can't necessarily assume that because someone is homeless, their self-care should be poor. But if you see someone that you suspect might have a psychiatric condition, you might want to talk to them if you wanted to, if you felt brave and if you didn't feel threatened, and you shouldn't really, and find out what's going on and where they're at. And you might be able to even take them to the hospital yourself if you felt that that was necessary. But ultimately, I think that the police and the ambulance services are the port of call for those kinds of patients. Now, I know that often, I don't know, I see the police representatives here, I'm not always sure that the police know that that's part of their responsibility, because sometimes we've had experiences where we phone the police and we say, please go pick up this patient, and they'll say, no, but that's not our responsibility. And it is. It's part of the Mental Health Care Act, and it is legislated, and sometimes the person on the ground just doesn't know that. So if you're having difficulty, speak to the superintendent of that station, because the police are responsible for those patients and must pick them up and tell the police that you think that this might be a psychiatric patient, that they need to go to the hospital. And they'll be taken to casualties at either Chris Hani Baragwanath Hospital or Charlotte Macheke, which is previously the Joe McJed or Helen Joseph Hospital, or even to a local clinic. Because there's always somebody there, especially at the hospitals. There's a psychiatrist on call who will see the patient, assess them, and decide whether or not they need to be admitted. And if the people at the local primary healthcare clinic think there's a problem, they'll refer them on to the hospitals. And I know that it sometimes can be a battle between negotiating who does what, but essentially the ambulance or police services need to take these patients to the hospital. And of course a member of the public can too. Once they've been admitted at one of these institutions and they're stabilized, usually they stay for about 3 weeks, that's the aim. The idea is to keep them there for about 3 weeks. If they require further psychiatric intervention, then they get sent to us, or Sterkfontein, and then in Johannesburg, in Pretoria, it's Pretoria Academic to Weskoppies. And with us, we try and keep them as little as possible as well, but 3 months on average. I can't remember, yeah, it's about 3 months. The most recent is 2 months, I think, our average length of stay. But we've had patients. I had a patient many years ago on Ward 7, where Dr. Amasoy is now, but that was long ago, who stayed for 12 months. She was a very, very, very depressed woman who stayed for 12 months with us. The other issue is, and this is also a very interesting something for this audience, is how do we keep these patients in the system? Because once they're at us, we can treat them, we stabilize them, they go and they have OT, and they have maybe attend psychology groups, the social workers intervene.
What's OT?
Oh, sorry, OT is occupational therapy. Are there any OTs here today? No, because I'm usually quite mean to the OTs, and I say, patients bored, they need to do some basket weaving. But actually, occupational therapy is about rehabilitation through activity. And it's not just rehabilitation, also assessment. The OTs can assess whether the person can go back to their job or not, how their level of functioning has declined, what areas of their functioning has suffered, and they then also do all sorts of activities that rehabilitate the patient, their concentration, their capacity for self-care, etc., etc. I'm not an OT, so don't quiz me on that. So they have a full multidisciplinary intervention. But what do we do once we finish treating them? Where do we send them? And I know that we have 2 social workers here today. They can also tell you that there are very, very few chronic beds in Gauteng where we can send our patients once we've stabilized them and they're doing well. They might need another 6 months or a year of rehabilitation in a structured environment. And the structured environment is very important because there are people there to monitor whether they're taking their medication, whether their sleep patterns are correct, whether their eating patterns are correct, their social interaction and activity in a reasonably friendly environment of other psychiatric patients. So the structured environment is a very, very valuable resource for these patients. And those are the step-down facilities we speak about. Or we refer them to the primary healthcare clinics that initially launched the whole process, where they're then followed up by a psychiatrist and hopefully a psychologist or a social worker and OT in those clinics. They're still very under-resourced. Now the problem is that we have too few step-down facilities and they're very under-resourced. So some of those facilities don't have a psychologist. They maybe have just one psychiatric nurse, if that. They may not have a social worker or an OT. They have a doctor that visits maybe once or twice a month. And so you have a lay community managing quite a specialized specialist intensive type of patient population. Now, often we send them back into their community, to the primary healthcare clinic and their family, and families don't understand psychiatric illness. Their community doesn't understand psychiatric illness. Often friends will not be friends anymore once a patient comes back and it's been discovered that they're a psychiatric patient. And because of that isolation and the lack of support that these patients experience, there's then a poor adherence to treatment and relapse. And so ideally, what we'd like to do is keep them in the system. We're not allowed to keep them for longer than a year. In fact, we're not really supposed to keep them for longer than 3 months. And after 6 months, we have to start writing reports motivating why the patient's still with us. And then after, I think, 9 months, we have to write another report. And after 12 months, we have to write another report. So technically speaking, we need to keep them in the system, but we have to down-refer them. Now, a thought just to keep with us, just to maybe stimulate your own thinking, is that it seems that psychiatric illness can lead to homelessness. But don't forget that homelessness can also lead to psychiatric illness because of the stress, the trauma, the victimization. Eventually, a person's capacity to cope with their environment is overwhelmed by the circumstances that they're in. And so it works either way. And that was it.
Ta-da. Thank you.